Welcome to the Dallas Duo podcast,
your weekly wellness coffee date.
We're friends in Dallas, always looking for the best ways to optimize our health
and have fun along the way.
Today, we're talking about perimenopause, a phase of life that so many women enter without a roadmap, without support, and honestly, without enough information. This episode is one that every woman needs to hear, especially if you're in your 30s or 40s and starting to think about what's ahead for your health.
Our guest is Dr. Cheryl Kinney, board-certified OB-GYN and menopause specialist based right here in Dallas with over 3 decades of experience caring for women. She's also the president of the Menopause Society, the leading organization of menopause clinicians worldwide. Dr. Kinney has dedicated her career and life to helping women understand their bodies, navigate hormonal changes, and build a foundation for long-term health.
We're diving into what perimenopause is, what women should be doing now to prepare for it, and how to advocate for your health in a system that often overlooks this stage of life.
Dr. Kinney, we're so honored you're here. Welcome to the Dallas Duo.
Thank you. Thank you. I'm very honored to be here.
So let's jump in. Let's define perimenopause. When does it typically begin?
So, our ovaries are remarkable organs, and for most of our life, they produce hormones that we need for reproduction. But a universal truth, to quote Jane Austen, is that all ovaries eventually fail for some reason. Perimenopause is really that transition leading up to the failure of our ovarian production of hormones. So during the perimenopausal transition, the production of estrogen and progesterone becomes less predictable. On certain days, your ovaries are producing both those hormones in their normal amounts. Other days, they're not producing almost any. And then you can have other days when they actually fluctuate way over bounds where they're producing more estrogen you need. So that's why some women will have a night sweat and then the very next day or two start having breast tenderness. The ovarian hormone production really fluctuate. And that's what perimenopause really is.
I think that's such an important distinction because in other areas of medicine, we see that organ failure is a slow process, but it's not erratic. And I think the one point that you mentioned is that it's erratic, that it's not just a slow, it's not a slow pattern that's predictable, right? Like we can't count on it being a 10% every year and linear. The erratic piece is, I think, the hardest part of it.
Right. And the symptomatology that production, the changes in that production can vary. And that's why so many women are kind of caught off guard. But it also explains why going to your doctor and having blood tests drawn can be very frustrating. You go in, you know you've been having symptoms or you've had your periods start to change, but your doctor tests your hormones and they're all normal. Well, you know you don't feel normal, but if they draw your hormones on a day where the ovaries are producing in their normal fashion, then everything is going to look okay, but you're still not going to feel well because in 2 days, your ovarian production will plummet. So that's what makes perimenopause so difficult to diagnose and manage sometimes. The other thing is that, because menopause, so the complete failure of our ovaries, our periods have stopped for a year, our ovaries don't really have any eggs left, our estrogen level, if we do have a blood test drawn, is so low they can't measure it. That can occur naturally anytime between the age of 40 and 60 or 58. So that means some women will start to have perimenopausal symptoms in their 30s. And you just don't think about it that early. And I think one of the things the Menopause Society is really trying to do is implement some type of clinician training so that we can provide anticipatory guidance to women. You know, pediatricians do a great job with puberty and childbirth, pregnancy. Every bookstore has, what to expect when you're expecting. And OB doctors in general do a really good job about helping prepare women, not for having children, but for the process of pregnancy and delivery. But we don't do that for perimenopause and menopause. So the Menopause Society is really trying to educate clinicians so clinicians can start giving this anticipatory guidance even as early age 35, just making it a routine part of an annual well woman exam.
I can definitely, speak to being caught off guard and the feeling the erratic nature of it. I feel like you've just described my life over the last few years, which has made me really interested in it and just interested in helping create awareness for other women as well. So I think if, education started earlier, that would certainly be, such a great start.
Well, and I think too that it would allow women to not normalize the symptoms because at the same time we're having perimenopausal symptoms, we are also usually heading to the pinnacle of our careers. We've got kids that have busy lives or they're going off to college. We've got aging parents sometimes we're trying to juggle. So it's a lot, and it's really easy to just think to yourself, well, this is just stress, or it's just aging, or I've just got this, and this, and this to do. And they really have, they don't connect the dots, so to speak. And so they end up struggling for a long time thinking, well, this is just the way my life is now. And it really isn't because the symptoms can be mitigated to a great degree.
Yeah, we've talked a lot about how just in culture in general, I think especially for our podcast demographic, it's the population that really is in that perimenopause to menopause window of that 7 to 10 years, and how just because something is a societal norm does not mean that it's normal or that it needs to be accepted. And I have, patients over and over again who say, well, it's just because I'm not sleeping and I'm tired and I'm working a lot. And that all of those things may be true.
Yes.
And also, we may also be in perimenopause. They can both be true at the same times. And I think that, as you're saying, the part that has caught so many women off guard is the lack of dialogue with a doctor in that 30s window. Because for me, even as a clinician, I was thinking I don't even need the menopause website until at least 50. In my head, like the idea of even educating myself on it wouldn't come until my 50s, which is so incorrect now knowing what I know.
Yeah. For some reason in my head, it was also 50. And so I don't know where that 50 came from, but in my head, I was like, I don't really need to worry about this until I'm in my 50s. And then, then going into my 40s, it all sort of hit me. And I was one of those people that was like, well, my daughter's going off to college. Of course, I feel stressed. I have all these things going on in my life. Of course, I'm tired. And so it really took me a few years to really understand what was happening and do some research and really understand.
So I think that's all very common, and that's part of the problem. Sometimes, perimenopause from a clinical standpoint is not diagnosed by laboratory tests, which again makes it difficult because we can diagnose high blood pressure by taking a blood pressure. We can diagnose high cholesterol by taking a blood test, or thyroid problems by a blood test. But perimenopause, that isn't a tool. And so we have to go by irregularity of periods and or the symptoms. And as you've said, a lot of the symptoms can kind of cross over with just a busy life, and women tend to miss them. So, four critical things to pay attention to as far as symptoms. Yes, cycle changes have to be one of them, but hot flashes and night sweats are one of the core perimenopausal symptoms that can occur. Sleep disruption is also one of those core. And then interestingly enough, mood changes, even more than brain fog, joint aches, dry skin, those type of things. But mood shifts really are a component of perimenopause. And one of the biggest uh, symptom that women don't even recognize is something called anhydronia, which basically means you don't really take any joy anymore in things. Your friends call you to go out to lunch. You're like, oh, I think I'm going to stay home and watch reruns. Well, that's not you. And women will come in and they'll know that I just don't feel like myself. They can't put their finger on it, but they know something is changing. So I think the take home message from all of this portion of your conversation is to really bring those changes and those concerns to a trusted doctor's attention. And hopefully then the woman will have those addressed.
That's really important that you highlighted that because, it doesn't always have to be a physical symptom. And I think people sometimes will associate hot flashes or night sweats with that. And I'm not really having those. So maybe it's not. But
Right.
that feeling of I'm not feeling like myself, or I feel like I'm more emotional and sensitive, or I feel like I'm even more introverted than I would be, or scatterbrained even. Those are things that are true symptoms. And I think it's really important that you brought that up.
This is a question, Dr. Kinney, that comes up later that we had planned in the podcast, but I am interested. You said make sure that you bring these symptoms to a trusted provider. And I'm interested if you know, like, what percentage of OB-GYNs are in that Menopause Society criteria, or like if you've measured maybe from past surveys, the population of OB-GYNs, like the percentage that feel confident in treating perimenopause, because I know that that has been a struggle for some patients that I see, that they go to their doctor and they state their symptoms and the conversation is not the one that we're having.
So here is the issue. As you probably know, the Women's Health Initiative that was published in 2002 dramatically changed the landscape as far as menopause, perimenopause, and hormone therapy is concerned. And that resulted in the next two generations of doctors not being trained, not just OB-GYN, but internists, cardiologists, family doctors,
Yeah, I
nurse
do.
practitioners, not being trained in menopause care. And the result of that is that we're finally, and charge is being led by the Menopause Society to really improve education early. So start in medical school, start imbricating menopause and perimenopause education in OB-GYN residencies. And here's the shocking thing that will answer your question. As of 3 years ago, less than 36% of the OB-GYN residencies in the United States even had 4 courses in menopause, and a course is usually 6 weeks, and that's less than one-third of all the OB-GYN. Most OB-GYN programs had 0, and a couple had 1 to 2 courses the whole 4 to 5 years of residency training and medical school training. So that's an 8-year period where the doctor who is sitting in front of you may have only had 1 or 2 6-week courses if they went to a good medical school. Because
Mhm.
again, most medical schools and residency programs had 0. So one of my big pushes as president of the Menopause Society is clinician education, clinician education, clinician education. And we are just making huge improvements in all that. So since 2023, we've really moved the needle on that part. And so is that going to help the women you see right now? No, but it will help the women that are coming behind us. And then for the clinicians in practice today, a national survey was done. And I think that More than family practice doctors, more than internists, gynecologists will have a better basic understanding of perimenopause. And there are fabulous menopause providers that are nurse practitioners, that are family
PAs.
practice doctors, yes, that are internists, endocrinologists, cardiologists. So they know a lot about perimenopause. But in general, a board certified OB-GYN doctor will have probably a superior fund of knowledge. Whether they're willing to spend the time and act on it, or whether they've kept up on that knowledge, that's a different thing. And so if you are with a doctor and your questions are not being answered, one great source is the Menopause Society website. It's menopause.org, and it has a Find a Healthcare Provider link right on the homepage tab. You can search for people in your area who are Menopause Society members, and it even shows a little decal if they've gone through the extra training and pass the certification test. So that's one trusted source. The American College of OB-GYN, unfortunately, does not have any searchable thing like that for patients, because that would be another good way to tell if the doctor was interested in menopause care or not. Overall, to answer your question, that was a long, drawn out answer. But the Menopause Society is made up of about 60% OB-GYN doctors. So there are a lot of us in there, and that includes internists and family practice doctors as well, who really have an interest in menopause care. But regular OB-GYN doctors, the national average about their comfort level with menopause and perimenopause is less than 40%.
Yeah, that tracks. I use that website weekly in my
Yes,
practice.
right.
Just to verify, I have very honest conversations with patients like, "Hey, I love that you saw your doctor, and it sounds like they may not be listening to you. I would love to just see if they're, in this group, in this realm, because in Dallas, we're so blessed to have such a saturated medical profession culture that there is always a second opinion available. And so trying to take advantage of that, or even virtual options for those in smaller suburbs. Because, like you're saying, the staggering number of years where that lack of educational provision was given, I don't think that that number is talked about enough.
No, and it's really, it's was desolate. I mean, there was essentially no training in menopause care and hormone therapy of any substance from about 2002 until in the mid 20 like 2015, 2016, it started to pick up. And part of that had to do with a reevaluation of the data of the WHI, and people started since 2007 really doing a deep dive into that study and saying, wait a minute, that's not really what that data says. And so once that charge became more the norm, medical schools and residency slowly began re-imbricating menopause care. We're lucky, as you say, because we live in Dallas, and UT Southwestern, when they did the national survey of OB-GYN residencies 3 or 4 years ago, UT Southwestern had at least 4 lectures in a 4-year training program. Those were 1-hour lectures. So they were one of the leaders in the country by just having 4 lectures in a 4-year period for menopause training. But they're much better now. The UT Southwestern has a lot more menopause care imbricated into their training program.
Well, that's my alum, so I appreciate it. Um, but it's interesting to me because so there's been like a recent push for like the lack of nutrition education that doctors get, and it's 6 hours. And so this actually makes me laugh because I'm like, well, did you know that they're only getting 4 hours in, a critical area that has to be handled by a doctor? So anyways, I just think it's like an ironic comparison that it's even less.
We're making great strides. So There now, most residency programs have some type of menopause training more than others, but we really are reversing that trend. We really are.
It's really encouraging to see that shift in the medical community, but also culturally. I feel like maybe in the past it was something that wasn't talked about openly as much. And now with social media and just people sharing amongst themselves some of the new books and resources that have come out, people are feeling more empowered and encouraged to talk, at least talk about it and get those topics out in the open. So I think that shift culturally is important too.
Oh, 100%. Much of what is happening in the menopause world is consumer driven.
Mhm.
100%.
Yeah, they say if you want something done, ask a mom, and I feel like it's all moms who are affected by perimenopause. So, we see that trend, but I
There's a lot of truth to that.
I'm I'm interested to know, and this is a good segue, why is this phase so critical to be addressed for long-term total body health?
So we have data from very young women who have ovarian failure from various reasons. They have to have their ovaries removed because of cancer, or they go through something called premature ovarian insufficiency, where their ovaries fail much, much earlier. I have a patient 18 who her ovaries failed at 18 years old. So we have data from those women that show that if you lose your ovarian function early, your brains, your bone, and your heart suffer for the rest of your life. And it's just critical to get those women on a substantial hormone replacement. So, replacing their estrogen, not hormone therapy, but making their estrogen the same as a healthy young 30-year-olds or 35-year-olds. So, that data was then extrapolated into perimenopause, and we know that there are benefits, particularly for long-term bone health, by getting women in perimenopause who are symptomatic on hormone therapy, if that's what they want. And then also, we have cardiovascular data that shows there are benefits in starting estrogen early in the perimenopause transition process. And there are probably cognitive benefits as well. So that is still out as far as a confirmed, but most of the data points in the direction that it's a positive to have perimenopausal estrogen loss addressed.
What if getting dressed, doing your makeup, and shopping for clothes finally felt easy and intentional? The Color Edit is a personalized experience created by image consultant Teresa Dillon of Reluctantly Styled and makeup artist Adriana Nestora, founder of The Makeup Edit. Together, they help you discover the colors that naturally enhance your skin, features, and personal style, then show you exactly how to apply that knowledge to your wardrobe, makeup, and everyday choices. You'll learn which shades brighten you, which tones to avoid, and how to confidently choose clothing, lipstick, and makeup finishes that work for you, not against you. It's practical, personalized, and designed to simplify your daily routine while helping you feel more polished and confident. Dallas Duo listeners receive 10% off their Color Edit experience. Visit The Color Edit Co. on Instagram to learn more and book your session. The Color Edit. Clarity in color, confidence in how you show up. If you could give every woman in her 30s a perimenopause prep checklist, what would be on it?
First of all, when you go into your doctor, this will help. If you go in and know your family history, have it written down, track your cycles. That's really important. And then other things to do for yourself would be to take things like sleep very seriously. Make sure you're getting good sleep. And if you're not, get it evaluated and addressed. This is also your time to build muscle. It's a time to make sure you're eating enough protein and probably fiber. I'll defer to the dietitian on that one. But those are some critical things that every woman in her 30s should do. And the last thing is, don't ignore heavy periods, because that can have consequences. And heavy periods don't have to mean something is wrong. It may just be you, but that can have a lot of nutritional consequences. So, again, I think when you go in for your appointment, know your family history, track your menstrual cycles. That'll save a lot of time for you and your doctor. And then take things like sleep, building muscle, and eating protein seriously.
Those are great pillars to start with. We agree. We talk about these things all the time, the importance of all of those. So it's great to hear
If
you say
if
that.
you weren't our favorite OB, you are now because you mentioned fiber. So thank you.
Well, like I said, it's amazing how much data is coming in, how fiber modulates so many things in the gastrointestinal system, and many women are plagued with bowel dysfunction, which just ramps up during perimenopause. So, if it can be addressed naturally with something like fiber, oh my gosh, what an easy fix!
Well, and also just I could go on and on about this, but like we know that the gut microbiome has such a strong relationship with hormonal health and gut diversity that comes in.
Yes, 100%.
Are there habits that you see patients participating in that help or hurt perimenopause experience that come in and mention symptoms and you're like, oof, stop doing that, or oof, do
Right.
more of
So,
that?
yeah. So I think chronic stress is bad, and it's bad for a lot of different reasons. But I think women do need to kind of take a step back and give that more weight and try to mitigate that to the best of their ability. I've already said poor sleep. I've underlined that 10 times already. That needs to be addressed. That is critical for, as you said, so many downstream consequences, including weight, digestive health, cognitive function, physical function. So, uh, get your sleep regulated and optimized. If you're smoking, don't do that. If you're drinking alcohol, now's the time to pull back. So many women drink their calories, and that is bad, bad, bad. Bad for brain function, bad for hormone fluctuations, bad for sleep. If you want to have 1 to 2 glasses of wine a week, that's fine. But more than that, I mean, look at the risk of alcohol use and breast cancer. It can increase a woman's risk of breast cancer 40%. There is no hormone on earth that's going to increase a woman's risk of breast cancer that much. So, women can do a lot of harm to themselves just by things that they think are innocuous. So, I think chronic stress, sleep, and then just kind of lifestyle things. And I've already mentioned, so those are the bad things that women can try to correct. The good things I've already really gone through is the building muscle, the focus on protein, and then sleep, sleep, sleep.
I'm really glad you bring up alcohol because I think that's a sneaky one that people sometimes dismiss or don't think plays a factor, and it certainly does. Comprehensive care is collaborative. Do you have any top referrals for this population, like physical therapists, pelvic floor therapists?
As I mentioned earlier, mood dysfunction is a huge component. It's one of the core things of perimenopause, and not all women have it, but even women without any history of a mood disorder at all can suffer tremendously during perimenopause, and it just ramps up, ramps up, ramps up. And right before your periods totally stop, that's when it's the worst. And sometimes without treatment, it will stay bad for years. So I have a group of wonderful therapists that I work with. I've got a handful of really good psychiatrists for those patients who need medication. Cognitive behavioral therapy, I've got great recommendations for apps because some of that can be done now with apps. And cognitive behavioral therapy is one of the non prescription interventions that we have data for that shows that actually helps mitigate hot flashes and night sweats. You can kind of kill two birds with one stone. The other issues, pelvic floor, absolutely. I have about 3 or 4 good pelvic floor physical therapy groups that I work with. I usually use the dietitians at one specific clinic for nutrition and metabolic health, but I am always open for suggestions. I do want to say that as far as acupuncture goes, that may help with stress management. I don't know the data on that, but as far as hot flashes, night sweats, those type of things, we now have data that shows acupuncture really isn't impactful. As I've said, cognitive behavioral therapy, good data, hypnosis therapy,
Mm.
good data for hot flashes and night sweats. There's something else called stellate ganglion blockade that's non-prescription but very invasive. But as far as other complementary therapies that really work for symptoms, most of the data is really, this is going to sound terrible, but it's industry produced. So you worry about conflict of interest when the company that makes the product says, oh, this is going to work. I like independent data, and you can't see it in my office, but there's a sign that says, in God we trust, all others must bring data. And I want my data to be independent. I want it to be researched, evidence based, not produced by the company that makes this herbal concoction or this device, something like that.
We talk about this a lot in office. I always try to have, honest conversations with patients and level with them and hear them. And they'll say, I'm trying acupuncture and it's really helping my symptoms. And I say, like, I love that for you. And I'm so happy it's lowering your stress levels. Although there's no data to support that it does X, Y, and Z, that doesn't impact that you personally are having a positive experience. But it's that fine line between not allowing someone's personal journey to then become evidence based research in their mind. Because I always worry about, well, if they tell their neighbor, they tell their friend, or they tell their aunt it's working and it doesn't work for that person, we don't want that person to think, oh, the data doesn't apply to me, or that, I failed out of the program when it isn't evidence in the first place.
So that is an excellent point, and I love your language. I may adopt some of that now when I'm speaking to patients because it expresses exactly what a doctor or a caregiver should express. That look, if this is working for you, as long as it's not causing harm, go forward with it. Because those databases that we have are, most of them are small, they're short life studies. If that particular intervention is working for a patient, the patient should continue it. So I 100% agree. And like I said, your language is far superior to mine. So I'm going to steal it.
I know we had talked a little bit about like symptoms and misconceptions and what is normal. I want to add on to that a bit. What specifically is happening in the brain during menopause? I know we had talked about like night sweats and mood changes, and I think a lot of people can relate to that because I know that night sweats and sleep is a big one. But I think the brain piece is one that doesn't come up as often that I really want to hone in on because that is such a strong change. And I want there to be more dialogue around it so that we don't normalize those symptoms.
So the brain is highly sensitive to changing estrogen levels, and the estrogen is a neuromodulator to some degree. When estrogen, night sweats, and temperature fluctuations interrupt sleep, sleep can directly impact the brain, and our brain function then manifests either as issues with concentration, verbal recall, written recall, organizational skills, kind of a brain fog. What happens in perimenopause to the brain, though, isn't manifested as a higher analytical kind of issue. It's more of that basic, just a little bit of forgetfulness. Oh, I went in the room and I forgot what I came for, or I had this, and this I wanted to get at the grocery store, but I could only remember 3 out of the 6 things. So that's how it manifests. But so many women come in and they're worried they're developing early Alzheimer's disease. We need to validate that and say, yes, that's worrisome that you think that, but here's the reality. Estrogen deprivation can have a significant impact on brain function. And again, it's mostly in those kind of day-to-day brain processing functions where you'll notice the difference. It's not like Alzheimer's disease where you're having huge lapses of memory or, again, your analytics. You don't remember how to work the microwave or you get lost in your car. So we can help them know that and reassure them that what they're experiencing is estrogen deprivation related and not something more serious. Now, what we always tell patients is that if a treatment regimen fails to lessen their symptoms after a time period, and that's usually 12 weeks, 3 months, when that's when estrogen kind of maximizes its effect. If they have persistent cognitive issues, then they need to be evaluated just like you would a 60-year-old who comes in with those brain complaints.
That's also important because it ties into that notion that a lot of women have of, I just don't feel like myself. And I think that that can be part of it, even feeling like more scatterbrained or forgetful, or even having a harder time making decisions than you might normally have. And I think that that's the hardest piece sometimes to communicate to your husband or to your partner of, I don't feel like myself. And they might look at you and think, well, you look the same. Like, I don't see you having any physical symptoms. And so it's harder to explain those cognitive, emotional effects that you're feeling. And so I think that that ties into that I just don't feel like myself notion.
I think for brain function too, it really impacts women in the workforce. They did a study in Britain a few years ago that showed that women were passing up promotions because they were worried about their cognitive function. And these were perimenopausal and menopausal women. And then they also did a study of doctors, female physicians in the UK. And it turned out that 30% of them were contemplating retiring early or changing their practice structure because perimenopause brain function was impacting them so, you both are right. This isn't a small piece of the pie for a lot of women, especially women who work outside of the home. Even for women who do work inside the home, it can be impactful. But especially if your, career is being threatened or challenged by your cognitive function, ugh, that's tough. At that point, you really do need to seek some type of relief.
Dr. Kinney, I want to talk about treatment. We've talked a lot about symptoms and what to look for and early awareness of that, but who is a good candidate for HRT, hormone replacement therapy, and what are maybe the nuances around that?
So, for women in perimenopause who decide that they are interested in some type of hormone remedy for their symptoms, we take into account, do they need contraception? Are they having abnormal bleeding? Are their periods a problem? And what are their symptoms? Because some women in that age range are best served with regular birth control pills. We have two birth control pills that are more specific for use in the perimenopausal woman. And we also have some contraceptive pills that also can function to help regulate periods. So, a birth control pill can really help the woman, as I said, with contraception, with her irregular periods, and with some symptoms. And the beauty of birth control pills is that they really are able to tampen down those high swings of estrogen. So you don't get the breast tenderness, you don't get the migraines, you don't get the bloating and PMS-like symptoms that you normally do. The birth control pills also can kind of stopgap when the ovary production of estrogen goes really low. So birth control pills can both tampen down the high swings but prevent the big drops. So for most perimenopausal women, as long as they don't have a lot of contraindications, birth control pills are a very viable option. But you have some women who don't need contraception. their periods are still regular, and all their problem is that their brain won't function, or they can't sleep, or their night sweats are so bad they're soaking their pajamas. So for those women, yes, they can still take birth control pills, but they can also take traditional hormone therapy. And that can be given as a patch, a pill, a gel, a cream, a ring. And as long as the woman's periods are still regular, she may not need accompanying uterine blocker, because any woman who is taking estrogen, if they're not having periods, they can restart bleeding, or worse, the cells inside their uterus can start to turn precancerous. It's called hyperplasia. So, to prevent that from happening, we have to give, along with the estrogen, which treats as the symptoms, we give a uterine blocker. That's usually some type of progestogen, but it can also be another product called basodoxepine. And progesterone comes in either oral tablets, which are nice. You take them at bedtime, they help you go to sleep. The progesterone can also be given in the vagina with a gel or a suppository. We have a wonderful progesterone containing IUD, and that is inserted up in a woman's uterus. It stays there for 5 years. That's off label use, but it protects the uterus from any unwanted impact of the estrogen. Most women have no bleeding. And the progesterone stays inside of the uterus, so the risk of progesterone causing side effects is very, very low. The IUD can also help women who are having, as I said, abnormal bleeding. It provides contraception. So for some patients, giving them traditional hormone levels of estrogen and combining it with an IUD or the progestogen or the basodoxepine is the best choice.
Are there certain populations that remain to be candidates that can't receive hormones?
So, those are getting less and less. As you both are aware, the black box warning labels were removed by the FDA. Thank goodness. Those needed to go. They never should have been put on in the first place. And because, again, the black boxes were placed there from data from that WHI study in 2002 that in retrospect had not been appropriately adjudicated. So the data wasn't as it was initially presented. So there are some women who are not candidates for estrogen therapy. But now everything is pretty much an individualized discussion with the patient. Women are rational, intelligent creatures. And yes, they may have had breast cancer 5 years ago, but they are now miserable. Their husband's ready to leave them because they can't be intimate anymore or don't have any interest in that. You know, they can't keep their job because their night sweats are so bad. And they should have the option of taking hormone therapy if it can remedy those here and now symptoms. And if a doctor sits down with the woman and says, your risk of your breast cancer coming back is 2%. If I give you hormone therapy, your risk of breast cancer coming back is 3%. Well, that's all a woman needs to hear. But when she hears it differently, well, your risk of breast cancer coming back is 2%. But if I give you estrogen, your risk is 50% higher that your breast cancer is going to be coming back. We can't structure conversations like that anymore. It scares women to death. So I think part of this has to be that we need to recognize women are individuals and they can make their own best decisions. It's our job as doctors and clinicians to help guide them, but we need to do it with absolute risk terms, not with these kind of percentages. They are just scary in most cases. and they're not really reflective of what the absolute risk really is.
Yeah, I think that's been the biggest learning curve for me is that as a dietitian who really cares about like a patient's whole body experience, I have patients that come to me saying, "Well, I had breast cancer 10 years ago and my doctor told me that I'm not eligible for HRT," and they're in their 60s. Or I have genetic elevated risk of cancer. And because of that, I'm not a candidate for HRT. And as somebody who's not a prescriber, I have to be careful with my scope. It's hard to sit there and hear the language that's being presented. And so this conversation is a personal one because I want those patients to know that there is perhaps alternatives with individualized care when risk stratification is considered.
And that's absolutely the key. So, we have a lot of data on women with hereditary breast cancers. We know that they are not at risk for increased risk of death from breast cancer. We know they're not at increased risk for developing breast cancer when estrogen is used. Women who have a history of blood clots. If you had a blood clot after you got a scope for a knee surgery or for plastic surgery, you should be able to take estrogen. We have good data that giving estrogen through the skin, so transdermally, doesn't really influence or increase your risk of blood clots. So all of those need to be individualized counseling rather than just a blanket no.
Are there risks of not having hormone support?
Gosh, yes. So, one of the biggest things, and this is a take home message, is that in the United States, as many women die every year after age 60 of a hip fracture as die of breast cancer. So, all this about wringing hands, oh, I don't want to take, estrogen because it will give me breast cancer. Well, good luck with that because hip fractures are terrible, not just because of the mortality, but 25% of women who have a hip fracture will never leave a nursing home. And I don't think that being in a nursing home in a diaper with a feeding tube is the look either of you are going for. So, bone health alone is something that we need to take more seriously. People talk about longevity, longevity, longevity. Well, living longer isn't the goal. It's a healthy life that is the goal. And that really starts by protecting our bones. Estrogen is FDA approved for the prevention of osteoporosis and fracture. So I think that message needs to be imparted. Women that have poor sleep, women that have mood dysfunction, that is horribly impactful for the family and work. Those things needs to be addressed, and the best way to treat all of those symptoms universally is probably hormone therapy of some sort. Sexual dysfunction can be devastating to a relationship. And so, again, some of these things can be easily remedied with very little risk.
Yeah, those are very powerful outcomes that you mentioned, those four things just alone. Are there other things that can be helped by hormone therapy that you haven't touched on yet?
So I think that was quite a list. I
Yes.
will say that we have worldwide the number one symptom that women complain about are joint aches and muscle pain. So before women go out and get that rotator cuff surgery, it may be worthwhile just making sure your hormones are where they need to be. And I'm not saying you shouldn't get a rotator cuff repaired, but I'm just saying that a lot of our aches and pains aren't necessarily just age related. They may be from estrogen deprivations. And if your joints ache, you don't sleep well and your energy's dragged down. So I just think that there's a lot of overlap and we need to keep that in mind if women are being denied estrogen.
All right, Dr. Kinney, I have two more questions for you. Right now, there's so much media on perimenopause, and I know you've had the honor to be an expert on many of those panels and documentaries and series. But are there red flag snake oil type solutions that you see right now that concern you, that make your eye roll, that when patients come into your office, you say, I know you've heard about that, but that is not a good option for you?
Three things. Number one, anything that says it's going to rebalance your hormones, you need to be skeptical about that. I think anything that claims that it's going to reverse aging, that's another big red flag. And then if something really promises to kind of fix everything, people should be cautious about that as well. And lastly, and this is the most important, make sure your listeners know that there is nothing that beats a thorough medical evaluation. Make sure your annual exam is up to date. These people that you're buying things from don't see you in person. They're giving you advice that may not be applicable or the best in your best interest. And ultimately, they are selling a product. So always, that buyer beware, that needs to be in the back of all of our mind. But those are the kind of big three red flag tip offs.
Okay. And my last one is, it's such a unique experience. I'm still like a relatively young dietitian. I just hit 11 years in practice. But for somebody who's been in this for 3 decades, I always feel like I'm a forever student and that things are always changing and I'm always reading the new research. Over the past 3 decades, where have the biggest shifts been for you in your practice and your treatment recommendations or recommendation options? What areas have expanded the most?
One area that's really expanded is addressing perimenopausal symptoms, because we used to make women, me included, used to make women wait until their periods had stopped a year and they were officially in menopause before they had any treatment. And that was the consensus guidelines. Now there's a big focus, get things started early. Those women, brain, heart, bones will benefit for the rest of their lives. There's even data that shows that in those young women who lose hormone function, that they'll benefit from a longevity standpoint. So that's been a shift. I also will say there's been a shift to thinking differently about aging. I have a big focus now for my patients on muscle strength and preserving muscle strength. And a lot of that is protein diet and just some kind of resistance training, or even if it's just walking, get moving, do something. And so those have been, I think, the biggest shift. I was trained and in practice before the WHI, so I never stopped giving hormones to women. But that part isn't been a shift, but I think the real emphasis on perimenopause and getting those women treated, and then also focusing on the things that are important for preserving healthy aging.
So interesting. You've seen so much in your field, right? Not every field is so dynamic and changing. And so I'm always interested, to know.
Well, thank you so much. We could talk about this much longer and continue to ask you questions, but we thank you so much for your time. Like I said at the beginning, I really hope that this is an episode that listeners will learn from and share and to spread the word and awareness around this. Where can our listeners find you, your website, practice, anything you'd like to share before we go?
My website is drcherylkinney.com, but my practice is really very, very limited to just consultation. So most patients, I would not serve them well. They are looking for someone who can do their annual gynecology exam along with providing guidance for perimenopause and menopause. I see women specifically who have seen providers, they were not listened to, or they were listened to and no plan was developed. And that's where I come in. I do menopause and perimenopause consults and osteoporosis consults.
Okay. And you mentioned that there were a plenty of resources on the menopause.org to find a provider.
Yes, a find a practitioner link is right on the homepage. They just click the link, type in their zip code, and it'll pop up the 10 or 15 doctors within a 10 to 20-mile radius who are members of the Menopause Society. And then again, it will identify those who have the additional certification as a menopause provider.
Final words for every woman in perimenopause, one piece of advice, what would it be?
Go into your doctor's appointment prepared, get a good symptom tracker, and make sure you have a trusted clinician because it's a partnership. Menopause is not a one-day thing. It's a transition. It can last for decades. You've got to have somebody that's going to be there on your team. And then the second thing is strength training. I just get those muscles strong early. It will serve you well because, like I said, none of us want to end up in a rehab for decades.
Yeah, it's all about that quality of life.
It is.
All right. Well, thank you so much for your time.
You're
Thank you,
welcome.
Dr. Kinney, so much. This
See
was
you guys.
incredible. I
Good luck
appreciate you.
and thanks for getting the word out.